And what did she have to say?
Well, she said everything, she did a, exam,
Uh-huh,
and she said everything was good.
good. So she didn't need to do any more surgery.
Mm-mm.
Okay, and she talked to you about radiation treatment?
Mm-hmm.
What's your understanding now?
Well, I just had a PET scan done,
Mm-hmm.
about a week ago, maybe.
Maybe
And-
two, no more.
It's not showing anything.
Okay, well, we should have it, you had it here, the PET scanner out of the glass building?
Out of the glass building.
Yeah, okay. So we can pull that up, look at it. Now, you also had a spot in your lung.
It's gone.
Okay, that's good news. Takes a moment to get into the system. We're almost there. Okay, so here's your PET scan. And you know, the PET scan is sugar water with a little radiation attached to each of the molecules.
Uh-huh.
So when this is called an axial view, we slice you all this way, all the way down. That's your brain area. That looks normal. Your throat, your shoulder joints. Do you have inflammation of your right shoulder? Do you have any problem with that?
Yeah.
This is your heart area here. Lungs look okay. I don't see anything that's drastic at all. The reason the heart lights up is when your muscle contracts with each heartbeat, you're using energy, sugar. So that's why that lights up like that. This is your liver, spleen, kidneys on both sides. Those all look normal. This is your backbone. When you feel somebody's backbone, that's what you feel in that little tip right there.
Mm-hmm.
This is getting down in close to the pelvis. Here's your belly button, just to tell you about where we are.
Mm-hmm.
Your bladder normally looks like that. That's your pubic bone in front. Here are your hip joints on each side.
Mm-hmm.
You should have the PET report here. It's your surgery report. Your surgery was done on the 14th of May, is that right? Does that sound right?
That sounds about right.
Okay. So this is a PET report. This was from the 3rd of July. That's that study.
Mm-hmm.
there was one focal area of increased activity in the midline of the pelvis. No other abnormal lymph nodes, etc. They may be talking about that little area right there.
I understood it was a crossover of, what was it, the intestines and the bowels? Is that what it was?
Looks like you have a loop of bowel there.
Yeah.
I'm not sure if that's anything to worry about. Dr. Scalisi, you saw her before this was done?
Yes.
Okay. She'll be able to look at that PET, because she has privileges there. I think she still does. So I value her opinion. She's an excellent doctor. I was chairman over there. I ran the radiation center for here and there, both sides, for years, so we worked together, a number of folks.
Yeah.
So in her original note, she said we probably would move to treat the whole pelvis with radiation.
Well, if there's nothing there, I don't see any reason to treat.
Yeah, well, the nothing there means what your eyeballs and what your fingers can touch. If you look at just a tiny little lymph node and ask how many cancer cells could be there, easily 1 million plus cells in that volume. We have no way of imaging the pelvis for microscopic disease, individual cancer cells. So if someone has, in your case, 30 years late recurrence, that's kind of stretching it. I think this is probably something new in that area. It can happen to any tissue in your body, any of us. So if we're looking at what can we do to keep this from coming back, then it would be to consider radiation.
Mm-hmm.
But you live in Grove Hill.
Right.
So you'd have to drive back and forth.
Exactly.
Monroeville's not available anymore.
Mm-hmm.
Bruton shut down. Thomasville and Grove Hill don't have any radiation. So you'd have to go north of that, Demopolis, before you could get someone to treat you.
Mm-hmm.
So really Mobile is kind of the best choice if you're gonna have treatment.
Mm-hmm.
Now, way back when you had your cervix cancer, you didn't have any radiation at all.
No.
Is that right?
No.
Okay. So really, you've never had radiation treatment any place in your body?
No radiation, no chemo, nothing.
Yeah. So if, what I think she's saying there is, well, we had evidence of a lymph node being positive. You could ask then, how many lymph nodes does the average person have here? At least 50,
Mm-hmm.
if not more. Most of them are real tiny, so you don't see them on the scan, but they're there. So if they opened you up and did a big surgery, you'd still see lymph nodes
Mm-hmm.
change. And the lymph nodes, well, I can draw pictures if they haven't told you. Yeah. If you take one of, let's just take a spot, let's say here. So that's really tiny. And we blow it up under the microscope. This is how it looks. You have fluid from your body comes in and it goes out, and there are millions of white cells here. And the purpose of those white cells is to identify any tissue that shouldn't be there.
Mm-hmm. Mm-hmm.
So some people believe we're all making cancer every day of our lives because a cell or two is damaged for whatever reason. If that's the case, your surveillance system, your immune system, is what detects those cells and destroys them.
Mm-hmm.
So that's one of the purposes. If you had a red hot toe because of an ingrown toenail and you had a red streak coming up, it'll stop at your knee and then show up again here in those lymph nodes, and they get so swollen and very tender.
Mm-hmm.
That gets the attention of most folks. So then we treat with antibiotics and it clears it up.
Mm-hmm.
Well, those pathways are already in your body. That's how you're made.
Mm-hmm.
If you didn't have the lymph nodes, then you'd blow up like the Pillsbury Doughboy. Because your body, because the artery is high pressure from the heart contracting. The low pressure is your veins, everybody knows that. But in between, there's the lymphatic system that takes excess fluid back to your heart. So it keeps that circulation going. If you have tumor that's in a lymph node, it can easily spread from one to the next because there are little channels that it follows. So that's what I think she's talking about in that area, that will probably move to external beam treatment.
Well, she hasn't seen this.
Yeah, I want to talk to her.
The only one she's seen is the last one. And I'd rather she look over this one before we make any type of decision.
I would too. I'm right on the same page with you. So your case is atypical. Okay.
Everything I do is atypical, trust me.
So when we talk about how to best follow you, is that with serial imaging and try to detect something as early as possible? Or do we simply intervene now and give you the treatment? I'll talk a little bit about the treatment so at least you heard it. As far as follow-up, the shortcoming of follow-up with no treatment is that we do not have the ability to detect tiny areas. So the risk is that something would set up and spread before we could detect it. So you just have to know that.
Well, I've been told that it's the squamous cell.
Squamous?
Squamous. And that it's a slow growing cancer.
It's faster growing than adenocarcinoma. In the uterus, in the womb, most of those cancers are adenocarcinoma. Just means glandular, it's Greek for glandular. Whereas all your skin, the lining of the tissues in the anal area, your throat, most of your lung tissue, that gives rise to squamous cell carcinoma. So there's a range from grade 1 to grade 3. Grade 3 being the most aggressive, grade 1 being the least aggressive. And many times with just a lymph node, they can't give you a good grade. They just say there's an abnormal tissue. We can go to your pathology report. And what they say is high grade with squamous differentiation involving the lymph node parenchyma. That means the center part. And it's a high grade cancer. So that's a grade 3.
Okay, so was that the first PET scan or is that?
No, this is the tissue they removed here.
Yes.
Okay. So you had how many PET scans?
I've had 2.
Okay, so we ought to be able to show that. Get out of this one and go back here, bring it up again. Maybe. Let's take that. Well, we're waiting on that. You haven't felt any lymph nodes above your collarbone or underneath here or down in the groin area?
No.
Okay, good. So you would describe your health now as being pretty good?
Yes.
Okay, good. This time's out, so if I'm talking too long, it stops. Signs us off. So it looks like you had a PET scan on the 2nd of April. That's your first one. The black and white pictures, this is where they were concerned here. This is your left side, this is your right. So this is called the left pelvic sidewall. And that's the CT only portion. Then they merge that with the color. And this is what it looks like. So clearly there's an abnormal lymph node there.
Mm-hmm.
I'm just looking at the rest of your pelvis. Okay, so we can reduce that. And look at your post-op pelvis. This is 3rd of July. This is the one that we looked at first. And we compare them side by side. And try to get them pretty close to the same level. So here's the tumor, and you don't see that anymore.
Mm-hmm.
And then the official report. The bowel loop is the only thing that showed up. That's what we looked at over here.
Mm-hmm. Mm-hmm.
No definite evidence of recurrence or metastatic disease on the most recent one.
Mm-hmm.
So that's kind of where we are right now.
Mm-hmm.
And what the term that would be used if you decided you wanted some form of treatment is called postoperative radiation, and it's given to destroy any microscopic disease.
Mm-hmm.
So what would that consist of? Typically, for someone living right here in town, it would probably be 5 weeks of daily treatment, Monday through Friday. If we just want to zoom in on that one little area where you did have it, above and below it, some small fields, then that's called stereotactic body radiotherapy, or SBRT.
Mm-hmm.
The difference is the stereotactic body is given twice a week for 2.5 weeks, so you're not coming every day. So that would be a consideration, though not be a first choice. The first choice would be to cover the lymphatics in the pelvis that still are there, if you were going to have treatment. If you would decide you didn't want treatment, then we would have one of the doctors, Kim Noddy, for instance, but someone would follow you periodically and get another PET probably in 3 to 6 months.
Mm-hmm.
And if something shows up, then rethink
Mm-hmm.
the decision, basically.
Mm-hmm. Well, actually, I'm supposed to see Dr. Kim Noddy this afternoon
Oh, good.
at 2:15.
Let's see what he has to say.
Mm-hmm.
As far as the radiation treatment, the daily treatment means that you're coming in lying on your back. Your legs are distended, but we put a bolster pillow here to take the pressure off your back. It's a real hard table. And the machine rotates around you and treats where we want it to go in the pelvic area. The rest of your body's not affected. So common questions: will you glow in the dark? No. Will you set the alarms off at the airport? No. Will you lose hair? Typically no, nothing here. Eating, drinking, all that stays the same. The side effects we do expect: tiredness after however many treatments we give you. That'll get better usually over 3 to 4 weeks after we finish. In the area of the pelvis, there's the bladder, the rectum, the small bowel, the colon, the big bowel. And of all those structures, the most sensitive is your small intestine. So that determines how much radiation we give with larger fields treating the pelvis on a daily basis. And that's about 5 weeks of treatment.
Mm-hmm.
It's just the opposite for the small fields. We're ignoring everything else and focusing very tightly. But again, the target's not there anymore.
Mm-hmm.
We have to go back to the pet, bring it in, and say, here's where the target was, and that's what we're trying to clean up. So two different perspectives. As far as the rectal area, you may have some loosening of the bowels, rarely constipation. Nausea and vomiting with just radiation alone is atypical, and we're treating the pelvis. So you can go about your normal activity. When you get the radiation, you don't see or feel it. It's damaging tissue though. So that's why it's critical to be as tight as we can and avoid all the other tissues. So that basically is the radiation treatment. Nowadays, we shape the beam so your hips get less radiation and lower chance of developing arthritis years down the line in the hips. Not perfect, but it helps. You're not radioactive, so you're not any children or pregnant ladies or whatever, there's not an issue there. They can be
Good,
around you.
because I'm raising 3 of my grandkids.
How old are they?
One just turned 4, 9, and 11.
Oh, little ones. Okay. And full of energy. Yeah. So your energy may be affected a little bit by the radiation. If we were trying to do everything possible to keep this cancer from coming back, not knowing where it started, then it would be whole pelvic radiation. If we're trying to just focus in where it was, that would be where we would do it twice a week for a while. The worst problems that could occur with radiation is if you had an obstruction. When he went in to do the surgery, his op note points out how many adhesions or scar tissue you had. Well, this surgery also causes scar tissue. Then we come back with radiation, we can cause scar tissue. And if that wraps around your small bowel, that can cause a blockage, which is serious. And it may not be reversible other than to go in and do big surgery. So that's the biggest concern, and that would be what dictates how much radiation we give to anybody in this setting. Outer skin, you probably won't notice much change there. As far as arms and leg function, no change. That would be highly unusual, less than 1/10 of 1% of ever having a problem there. In the rectal area, you could see tiny little vessels form in the lining of the rectum, though unusual it can be with these doses. And if that happens, you could have one of them pop and have a trace of blood on the toilet tissue or on the stool, much like a hemorrhoid type. If you had that, it goes away in 2 to 3 days. Rare that we would see with this dose that we would see any worse situation. Now, if you still had tumor, gross tumor, then everything I told you doesn't apply because we have to give more radiation, higher doses, and we have to be cognizant or aware of the potential complications when we talk about that. So anytime someone like Scalisi or I get involved, it's usually a team effort. We're putting our heads together and saying what's best for you as an individual, of course, with your input as well. So that's, in a nutshell, that's about everything I can think to tell you. Anytime we give radiation to anybody, we treat from 1 year of age all the way up to hundreds, we have to tell them there could be a slight risk of us causing a cancer down the line, 10, 15 years down the line. That typically is a sarcoma, not a carcinoma. And if it occurs, then we treat it as if it was brand new and had nothing to do with anything, and then decide what would be the best thing. The risk of that is anywhere from 1 in 10,000 patients treated to 1 in 100,000. So it's very small, but it's still not zero. Questions about any of that? Okay, can you have a seat over here? Let me listen to your heart and lungs. As far as your abdomen now, are you sore at all?